This is a dictation on patient Keith, K-E-I-T-H, Diane, D-I-A-N-E. Please address it to Dr. Dirges, J-I-R-J-I-S, initial L, paragraph. Date of visit, APR 3/19, paragraph, DGX. OA, stop, PSA, stop, PSO, paragraph, meds, sulfasalazine, 1000 mg OD, paragraph, allergies, none, paragraph, interim history. All the headings bolded, please. Diane has been doing well. Stop, she has not increased the dose of sulfasalazine to twice daily. Stop, she is not experiencing joint pain, swelling, or stiffness, apart from some stiffness over both first MTPs that are affected by OA. Stop, she also has no symptoms of dactylitis or enthesitis. Stop, her psoriasis is mild and affects one of the feet, paragraph. P/E, mild psoriasis involving foot and nails. MSK exam reveals OA at both first MTPs. There was reduced ROM in both joints with no swelling or tenderness. Stop. Other joints were not tender or swollen, and there was no evidence of dactylitis or enthesitis. Paragraph. Impression. OA and psoriatic arthritis. Stop. Diane's symptoms are mostly related to OA at both first MTP joints. She may benefit from obtaining custom-made orthotics to make walking and exercising more comfortable. If she is becoming more symptomatic, I would suggest she increases sulfasalazine to twice daily. She agreed with this plan. Paragraph F/UP, fall/19. Stop. Hall, H-A-L-L, Brenda. B-R-E-N-D-A. Please address the Dr. Duncombe, D-U-N-C-O-M-B-E, initial J. Paragraph, date of visit, APR 3/19, paragraph, DGX, OA, stop, psoriatic arthritis, stop, psoriasis, paragraph. Meds, estradiol patch, citalopram, Crestor, Synthroid, esomeprazole, and perindopril, as well as ASA, omega-3, vitamin D 2000 IU per day, and coenzyme Q10. Paragraph, interim history. Brenda has been experiencing pain over DIP joints and this has been a bit more pronounced since I've seen her last. As you recall, she has OA moderately severe in both knees, and she has osteoarthritis affecting also multiple DIP joints. There has been one erosion at the left fifth DIP joint. She seems to be more stiff than before. Also, her psoriasis has been flaring up, particularly at the scalp. She is using shampoo from her dermatologist, but this is not working. And paragraph. Physical exam showed MSK exam showed multiple DIP joints. Multiple DIP joints with possible synovitis at right third and second PIP. There was no evidence of dactylitis. She was tender in a couple of antesial sites. Paragraph, impression. Brenda's psoriatic arthritis has been flaring up. She was referred for x-rays of hands and wrists as well as blood work, and I discussed with her treatment treatment with Otezla. She would like Otezla, which might be beneficial for her psoriatic arthritis as well as psoriasis. She would like to think about that therapy a bit more, and we agreed to see each other in follow-up in June. Jackson. Jackson, Bruce, Bruce. Please address the Dr. Hooper, Hooper. Initial C, paragraph, date of visit, APR3/19, paragraph DGX. OA, stop, likely SLE, stop, history of Raynaud's, as well as long-standing history of dry eyes, stop, HX of HTN, dyslipidemia, and prediabetes, stop, right TKR 2015, stop, IBS, paragraph meds, ramipril, atorvastatin, cholestyramine, Celebrex, PARN, HCTZ, coenzyme Q10, and fish oil, paragraph allergies, ASA, elastoplast, and Demerol, stop, interim history. Bruce had laboratory investigations done. They were essentially normal except for positive anti-double-stranded DNA at 27 with negative ANA and ENA and low C4 at 0.12. ESR was 8. He had X-rays done of his shoulders and sternoclavicular joints as well as hands and wrists. There has been evidence of joint space loss at the MCP joints, mostly in second third on the right, greater than the left, in addition to some osteophytosis and also minor OA at glenohumeral joints. Ultrasound showed some synovial thickening and effusions with no clear evidence of synovitis. Ultrasound of the right posterior neck showed lipoma. Stop. He's still experiencing arthralgias. He started to take Silibin, Silibin, and that has improving, and this has been improving his symptoms. Paragraph impression. Bruce has OA and possibly has also a mild SLE. Stop. He agreed to start Plaquenil 200 milligrams twice a day. I discussed with him benefits as well as possible ASEs of that therapy, including rare possibility of ocular toxicity and tinnitus. Stop. He was referred to his optometrist. For regular checkouts. Stop. Paragraph F/UP AUG/19 patient Salotera SALOTERA initial A. Please address the Dr. Ghaznavi GHAZNAVI initial S. Paragraph date of visit APR3/19 paragraph DGX SLE 2014 stop. Likely psoriatic arthritis. Stop. HX of Hashimoto thyroiditis, psoriasis since childhood, and mild asthma. Paragraph meds prednisone 5 mg POOD, ASA 81 mg OD, metformin 500 mg OD, levothyroxine and vitamin D. Paragraph allergies none, intolerance to Imuran and plaque inguinal. Paragraph interim history. Amit had MRI of the spine and SI joint done, which showed no evidence of spondyloarthropathy. She had a small hemangioma in the sacrum, and follow-up images were advised at 6 months by MRI. Stop, as she has cut back on prednisone. She experienced more pain at the PIP joints as well as through her feet. MRI of her feet showed some synovitis at the left second and third and right first and fourth MTPs. Stop, her psoriasis is flaring up. Stop, she would like to consider pregnancy. Paragraph. P/E showed stress pain across MTPs and several tender PIP joints, mostly in the right hands, including second, third, and fourth, with the effusion at third and fourth PIP. Paragraph. Impression. SLE, number 1, SLE, Amit will remain on current dose of prednisone. Number 2, likely psoriatic arthritis with no evidence of spondylitis on MRI of the spine and SI joints. Stop, she would benefit from therapy that could address both psoriasis and psoriatic arthritis and allow her to be pregnant safely, and therefore we chose therapy with Cimzia injections, 200 milligrams every 2 weeks. I will apply for coverage through her private drug plan. Stop, she agreed with this plan. Stop, paragraph F/UP 4/112. Array, RAE, Diana, DIANA. Please address it Dr. Chung, CHUNG, initial KL. Paragraph. Thank you very much for referring Diana, who is 41-year-old esthetician who works part-time with respect to possible inflammatory arthritis. Paragraph. She has been troubled by pain in her hands for about a year, but the last 6 months have been particularly difficult. The pain is present at the bases of both thumbs as well as PIP joints, and she also finds her hands slightly shaking. This is usually not related to any particular activity, although work makes it worse. She's not experiencing any visible joint swelling, no numbness, and no paresthesia. She experiences at night myoclonic jerks. She has been working part-time as an esthetician and is not doing too much of massage therapy. Paragraph. She has no history of rashes, including psoriasis, IBD, or uveitis. Paragraph. Meds. Doxycycline on and off. Paragraph. Allergies, none. Paragraph. FHX, Motherwell, father type 2 DM. Paragraph. Diana has history of scoliosis and degenerative changes in the spine. She is not suffering from significant back pain and stiffness, especially at night or in the morning. The trouble with back pain have been lasted for about 15 years, and she hasn't noticed any significant restriction in mobility. Stop. She also has history of rosacea. Paragraph. Meds. Doxycycline on and off. Paragraph. Allergies, none. And I think I already dictated that. If so, please take it out. Paragraph. She's lifelong non-smoker. Paragraph. P/E revealed normal general physical exam with no evidence of psoriasis, rheumatoid nodules, or nail lesions. MSK exam revealed joint line tenderness and stress pain at both CMC joints. She also was tender over right second and third PIP with mild, with no clear evidence of synovitis. There was also no evidence of dactylitis. Paragraph. Blood work, ESR5, CRP 2.3, negative RF and ANA, normal TSH, creatinine 62, ALT 14. Paragraph. Impression. Diana most likely has osteoarthritis. To be sure she has no evidence of early synovitis, she was referred for power Doppler ultrasound, and she will also have x-rays of hands, wrists and feet and relevant blood work. I will call her in case her investigations are abnormal and would require further follow-up. Stop. She was advised to use Advil 400 milligram twice a day, as well as Voltaren Imugel up to 3 times a day, in addition to splinting at night. I will follow up with her in July. Stop. Thank you for referring Diana for consultation. Stop. Patient Kurcz, K-U-R-U-C-Z, Diane, D-I-A-N-E. Please address it to Dr. Gali, G-H-A-L-I, initial A, paragraph. Thank you very much for referring Diane, who is 77-year-old female with respect to possible inflammatory arthritis and connective tissue disease in view of her abnormal ANA serology. Paragraph. Diane has been experiencing pain, in quotation please put all over, but for many years, but the most significant pain is in her both knees as well as hips and lower back. She is limping with walking due to pain in the left knee. She is not experiencing any joint swelling. She has no history of rashes, photosensitivity, mouth ulcers. She does have some hair thinning. She has history of rosacea. There is no history of serositis, seizure, psychosis, or thromboembolic complications. She has one miscarriage in the first trimester. Stop. There is no history of psoriasis, IBD, or uveitis. Paragraph. Current medications, Tylenol, PRN, and gabapentin. Paragraph. Allergies, Demerol, in brackets severe intolerance. Stop. She had hiatus hernia surgery and was told to avoid NSAIDs. Stop. She has in the feet neuropathy secondary to CMT. Paragraph. FHX, uncontributory. Paragraph. She's non-smoker. Paragraph. P/E showed revealed elevated BMI, BP 125/70, no pedal edema, normal heart sounds, lungs clear to auscultation. MSK exam revealed well-preserved mobility in both hips, patellofemoral crepitus, both knees, and medial joint line tenderness, both knees, with no effusions or Baker cysts. Stop. 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 There was no evidence of synovitis. Paragraph. Blood work, ANA 1/80 SP/homo pattern, normal CBC and differential, ESR 6, normal urinalysis, ALT 23, negative RF, CRP 9.1, normal B12 and TSH. Weight-bearing x-rays of both knees showed moderately severe OA bilaterally, more so in the right knee, including medial and patellofemoral compartment, mild to moderate OA, right knee. Degenerative changes in the lumbar spine. Paragraph. Impression. Diane has osteoarthritis and there is no evidence of inflammatory arthritis or connective tissue disease that I'm concerned with. She does not require at this point any additional investigations. Stop. I discussed with her treatment of osteoarthritis affecting both knees, and she was also referred to Arthritis Society of Canada for additional education. She would benefit from weight loss and possibly physiotherapy course. She will continue glucosamine sulfate and will increase Tylenol arthritis pain to 2 tablets 3 times a day on a regular basis. She received cortisone and viscosupplement injection in the past, and those were not very effective. However, cortisone can still be repeated. She may also consider PRP. Stop. Thank you for referring this person for consultation. Stopovich, Frankovich, Joanne, Joanne, initial M, paragraph. Thank you very much for referring Joanne, who is 49-year-old female educational assistant, regarding possibility of connective tissue disease in view of her abnormal ANA serology. And paragraph. Joanne has been experiencing Raynaud's in both hands for a year, and possibly feet can be affected as well. She brought pictures with typical color changes for Raynaud's affecting all of the fingers. She has never experienced any ulcerations. And her Raynaud's are occurring daily. She has no history of excessive fatigue, fever, chills, weight loss, or lymphadenopathy. There is also no history of photosensitivity, recurrent mouth or nasal ulcers, and no hair loss / alopecia. She has a dry mouth and dry eyes for about 22 years and has been on treatment with Restasis. She had keratitis in the past. 2 years ago, she was investigated for diarrhea and right lower quadrant abdominal pain. Her colonoscopy was normal. She later on developed constipation, possibly related to iron supplements. She has fairly dry skin with no rashes. There is no history of chronic heartburn, dysphagia, seizures, psychosis, serositis, or thromboembolic complications. Paragraph. Current medications. Restasis and Valtrex, PRN, a paragraph. Allergies, none. Paragraph. Surgeries, fibroids at age 21, eye surgery and 3 C-sections. Paragraph. FHX, both parents well. She's non-smoker. Paragraph. Physical exam, BP 123/70, no pedal edema, no rashes, no telangiectasia or petechia, normal heart sounds, lungs clear to auscultation, no parotid or thyroid enlargement, no lymphadenopathy. MSK exam revealed no synovitis. Hand exam revealed no periangle erythema. Digital pulp, no periangle erythema, dropped capillaries, digital pulp atrophy or ulcerations. Paragraph. Blood work, ANA 1/640, speckled, borderline RF at 16, creatinine 63, ALT 20, ALP 66, WBC 3.4, RF 15, CRP 0.3, normal TSH, T3, T4. Paragraph. Impression. Joanne has a history of Raynaud's for about a year, leukopenia, and abnormal ANA serology. She should be investigated towards possible connective tissue disease. And she was given requisition to do more in-depth blood work. She will also complete microscopic urinalysis and chest X-ray. We discussed treatment of Raynaud's, especially in view of minimizing her symptoms and protection from cold. She was given appropriate pamphlet regarding that. I will follow up with Joanne in December. And sooner, if any problems arise. She agreed with this plan. And to win, WYNNE. Ronald, RONALD, initial G. Please address to Dr. Snyder, SNYDER, initial N. Paragraph. Thank you for referring Ronald, who is 69-year-old male with respect to possible PMR. Paragraph. Ron's symptoms started around Christmas time and peaked in January. He developed pain and stiffness in both shoulders. neck and subsequently hips and pelvic girdle. He was extremely stiff in the morning and had difficulty mobilizing. Stop. He has not developed any headaches or double vision, and he has no symptoms suggestive of jaw or arm claudication. Also, his joints have not been swollen. His energy level declined. Eventually, he started prednisone 35 mg/day 2 weeks ago, and his symptoms almost completely cleared. He is currently asymptomatic. Paragraph. He has a history of dyslipidemia, HTN, and mild depression. Paragraph. Current medications: prednisone 20 mg OD, Cipralex 20 mg OD, Wellbutrin 150 mg OD, or Olmetec 20 mg OD, Norvasc 10 mg OD, Crestor 10 mg OD, ASA 81 mg OD. Paragraph. Allergies none. Paragraph. FHX uncontributory. Paragraph. Ron has no history of insufficiency fractures. Paragraph. P/E 122/70, no pedal edema, normal heart sounds, lungs clear to auscultation. MSK exam reveals multiple degenerative changes in his hands, including DIP, PIP, and less so CMC joints of both hands, with no evidence of synovitis. There was no tenderness throughout ROM in either shoulders or hips. Paragraph. Blood work from FAB19, hemoglobin 133, normal W platelets and diff, CR86, GFR 80, ALT 20, TSH 4.07, normal T4, ESR 31, CRP 42.3, negative RF. Paragraph. Impression. Ron has polymyalgia rheumatica in brackets PMR. Stop. He will continue prednisone 20 mg OD till April 30th, and on May 1st he will reduce to 17.5 milligrams for 2 weeks and will be reducing further by 2.5 milligrams every 2 weeks until he reaches 9 milligrams per day, and he will stay on this dose for 1 month. He was also started on Acton LDR 35 mg OW along with vitamin D3 2000 IU per day to prevent GIOP. Stop. He was referred for baseline BMD as well as additional blood work and was supplied with requisition to do blood work monthly. Paragraph. F/UP/JUL/19. Stop. Thank you for referring this patient for consultation. Stop. Patient Mio, MIO. Please address it to Dr. Chung, CHUNG, initial KL. Paragraph. Thank you for referring Liz, who is 57-year-old female with respect to possible systemic lupus. Stop. She has a history of liver cirrhosis and has been a patient of Dr. Pham. Paragraph. She is recovered alcoholic and has been investigated for liver cirrhosis by Dr. Pham. She had CT scan done in 2018 showing nodular liver and also is known to have mild splenomegaly and esophageal varices. She will be booked soon for a liver biopsy. Stop. She has history of arthralgias that are quite generalized, involving knees, hips, and hands, with no clear evidence of joint swelling. She has no history of rashes, photosensitivity, recurrent mouth or nasal ulcers, and there is no history of significant hair loss, although there has been some thinning of the hair over the years. There is no history of serositis, seizure, psychosis, or thromboembolic complications. She always has some mild shortness of breath and cough since she is ex-smoker. Stop. A chest X-ray done a month ago has been normal. She is not experiencing any visible joint swelling. She has no symptoms suggestive of either Raynaud's or Sjogren's. Stop and paragraph meds, Pantalog 40 mg OD, probiotic and sporadically ibuprofen. Paragraph allergies none. Paragraph FHX uncontributory. Paragraph P/E. BP 124/70, no pedal edema, no rashes, no telangiectasia or petechia, no thyroid enlargement or lymphadenopathy, normal heart sounds, lungs clear. To auscultation MSK exam revealed no evidence of synovitis. Stop. She had evidence of palmar erythema. Stop. Blood work ANA 1/320 SP/homo pattern, normal hemoglobin A1C, creatinine 51, ALT 8, AST 14, gamma GT 21. Normal urinalysis, hemoglobin 119, normal WBC, platelets 127, normal differential, positive ANA 1/320 SP /homo/nucle, CRP 2.9. Paragraph impression. Elizabeth or Liz has been experiencing diffuse arthralgias and has abnormal ANA serology. She also has a very mild thrombocytopenia, likely related to her a previous history of alcoholism and liver disease. She has no signs or symptoms of connective tissue disease, and I do not suggest to do any additional investigations at this. And I don't suspect she has connective tissue disease. Stop. She was referred for additional laboratory investigations, and I will call her in case of any concerns. Stop. She agreed with this plan. Stop. Thank you for referring this patient for consultation. Stop. Anna Jeruszyńska.